Hey, Brad. Hey, Brad, can you hear me? Hey, Brad, can you hear me?
Okay.
Okay, so tonight, as I was telling you, Roy, what I'd like to do, and hopefully, Brad, if you can hear me, if you can chime in, that'd be great. Because if it's just going to be the three of us, then I'd like for everybody to be able to talk and and share and question and whatnot. But I want to present four different cases. They were all done within the same couple of days. Um, of people who had suspected ulnar neuropathies at the elbow. So,
Mhm.
just utilizing techniques that you've learned, maybe adding some techniques that you may not have learned. But if you recall listening to Dr. Kimura talk, anytime you suspect that a patient has a focal neuropathy, when we're doing our nerve conduction studies, it's important to be willing to go short as far as a segment is concerned. You don't usually pick up focal entrapments by using long segments unless the focal entrapment's just really severe. So when you suspect that a patient has a focal entrapment, i.e. a carpal tunnel or a cubital tunnel or a peroneal neuropathy at the knee, a standard 14 centimeter segment or even sometimes a standard 10 or 12 centimeter segment isn't short enough to pick up a problem that may be there. And that's part of the reason why we teach to do ulnar neuropathies around the elbow at 8 centimeters. Some people do them at 10. And when there are comparative differences, to be willing to do short segment testing like inching uh,
Mhm.
studies to be able to identify focal entrapments when they're there. Same thing with carpal tunnel. The practice parameter in carpal tunnel, and the next time I present, I'll bring forward several cases of carpal tunnel with typical tests and then some comparative tests to help to tease out the presence of a condition that might be there, whether it's there superimposed on a more diffuse process or whether it's just a very mild condition. Um, so at any rate, we've got to be willing to be considerate of patients that present with suspected conditions. And so today, all I want to do, I'm going to go through four cases of suspected ulnar neuropathy at the elbow and just show you guys data and talk about clinical decision making in ulnar neuropathy at the elbow. Is that reasonable, Roy?
You bet.
Okay. So the first patient, fairly young. I think that this test was done in 2016. What's the date on that?
Yeah. Yeah.
My
5'9".
file shows up. Okay, so
Yeah.
May of 2016, has a history of some cervical and lumbar pain with referred pain in the upper traps, but he gets tingling paresthesias in the uppers greater than the lowers and predominantly in the ulnar distribution. And this particular patient had a thorough examination performed prior to the EDX with suspected ulnar neuropathy at the elbow as primary versus that being superimposed on a more diffuse neuropathy or radiculopathy. So we started the study just like any other. And in our sensory nerve conduction, standard sensories, I did a median D3 bilaterally, ulnar D5s bilaterally. And what do we see in those? Anything?
Well, I'm just trying to look here quickly. I see good median response looks like, but I would say just a little bit. You're just barely normal on your ulnar as far as
Okay.
your peak. I don't
So
know.
you're talking about amplitude?
Yeah, the amplitude. I mean, if I kind of look at that aspect, you know, I have a little bit of question there. I mean, of course, we look even at the wrist, and
Hmm.
we're normals, but like I said, I still think you're barely normal on either one of your ulnars.
Yeah. So that's enough still to say, well, okay, maybe this jibes with suspected ulnar neuropathy at the elbow. Just
Yeah,
as an FYI, we do the median. I do a median radial comparison to digit 1 for carpal tunnel comparisons, and they look fine.
yeah, yeah.
So then we do motor nerve conduction studies, and what do we see?
Let's see here. Well, let's say at the wrist we look all right. Of course, you got your below elbow velocity on both of those are low.
Which velocity is low?
Let's see that looks like hang on here. It's the velocity at below elbow, 37 and 45 for both your ulnars, left and right.
So it's a forearm slowing that's there? It's the velocity below the elbow?
Well, I'll look at this again because it's above the elbow, you're at 63 and 53. Below the elbow, you're at 37 and 45.
Okay, so I guess when you look at that segment,
Mm-hmm.
the wrist segment is normal,
Right.
2.8 and 2.8.
Correct.
Okay. The forearm segment is normal,
Yeah.
56 and 57.
Okay.
So
Sorry. Yeah.
from below elbow to the
To
wrist
rest. Sorry.
is normal.
Okay. Sorry about that. I wasn't paying attention. Yeah. You said the above elbow is slow.
No, the across elbow is slow.
That's what I mean. Sorry. My explanation is poor because, like I said, I don't normally do an axilla to elbow.
Ah,
Well, I have not been trained to do an axilla to elbow. Let's just put it that way.
so when you guys did I think that it's important in focal neuropathies to try to bookend, if you will,
Yeah.
normal
Yeah.
versus abnormal.
Okay.
So I would get in the habit of doing an axilla to above elbow
Yeah. See,
segment
I've never
in addition to
been
your
trained to
across.
even do axilla yet.
All you do is walk up another 10 centimeters or 8 centimeters in the medial intermuscular septum and stimulate the nerve again. It's very easy. It's really simple. And so I think you were trained to do like a 4x4 method across elbow, right? 4 below, 4
Yeah.
above.
That was originally, yeah. And then we've kind
Okay.
of gone 5 and 3 or 3 and 5.
3 and 5 is fine.
Yeah.
So 3 and 5, and then just extend when you're above 5. Just go ahead and stretch out to 13 and put another mark,
Okay. Yeah, I can do that.
and just make sure that you're along the medial intermuscular septum, so that you can clearly see here that these are across elbow.
Okay. Yes.
Okay. And so your table would have looked something like this.
Yeah,
Is that right?
that's correct.
Okay. So it's not an above elbow nerve conduction velocity, it's an across elbow nerve conduction velocity.
Okay. Yes.
So when you're writing this, how might you decide to say what we see here?
Oh, well, we'll say if we're saying what we're seeing here, we're seeing normal amplitude, but
I want you to say it like you were going to write it.
okay. All right.
I'm
So,
going to review. I'm reviewing your work.
okay. Very good. All right. So,
I didn't
and
spit my
looking
teeth in
at
my nose.
this, there is normal amplitude um, at the wrist uh, for both the right and left ulnar motor nerves with uh, normal velocity uh, at the wrist to below elbow segment and the above elbow to axilla. However, there is diminished velocity at the cross elbow segment for both the left and right ulnar motor nerves.
Okay. You said everything that needed to be said. The only suggestion that I would have is state the abnormality first.
Okay.
So if I were writing this, I would say the bilateral across elbow ulnar nerve conduction velocities are slow
Okay.
with normal adjacent velocities, distal latency and amplitude, period.
Okay.
Or as Mark teaches how to write, he would write selected nerves from the bilateral upper extremities to include, and he would list the nerves,
Hmm.
demonstrate normal latencies, amplitudes, and nerve conduction velocities, except with a colon, and then a new bullet that says bilateral ulnar nerve conduction velocities across the elbow are delayed or slow.
Okay.
But in terms of report writing, I think that it's important to characterize the most significant abnormality first, followed by what's normal,
Makes
so that,
sense.
so that you highlight it and you can see it real quick. And just in looking at the waveforms here, so we've in this motor nerve study, the sensory nerves were reasonably normal. The motor nerve conduction velocities are slow, both ulnar nerves at the elbows.
Hmm.
Waveforms, EMG was clean, didn't see any, and notice my selection of EMG.
Hmm.
I'm sampling hand muscles, ulnar, and on the other side, ulnar. Given important to sample the muscles that are supplied by the suspected problem.
Okay.
And then the spattering of other, C5 to T1 stuff.
All right. Yeah, I've done most of that. I I have not done brachioradialis so far, pretty much, but I
You
probably
haven't
should.
stuck. It's easy
I
stick.
have. Yeah, I know it's easy. I kind of got a list of what I did, but most of mine has been median so far. So yeah, I didn't. I
So
didn't. I
when I do an EMG, I usually start first dorsal interosseous. Then usually my next stick is the brachioradialis, then the
okay.
FCR, and then like the tricep bicep or the tricep deltoid, something like that.
Okay. Okay. Yeah, I'm getting tricep bicep deltoid usually so
Mm-hmm. Mm-hmm.
far. So yeah, I've got those down. But I tell you what, I've learned pretty quickly that if I've got someone, I've got to have the longer needle. I get up there.
Mm,
I had one. I got there and I ran out of needle.
yeah.
Yeah.
Yeah. You get some beefy arms. Don't
Yeah.
try not to use 25s on patients with fat arms for sure.
Yeah, I'm going to have to order longer because, like I said, I haven't had anyone that big yet.
So just in looking at the data, there's one of the things that I do a little different, and we've talked about it before. I usually am testing my sensory. Um, Sometimes my baselines look a little more choppy
Hmm.
because I test at 10 microvolts per division, not 20. So I see a lot more stuff on the screen sometimes because I
Yeah.
don't turn my gain down. I make it a little more sensitive.
Gotcha.
So here we see that there's your ulnar motor studies, and they're pretty clean straight across.
Yeah. Yeah.
And so how I wrote case one was bilateral ulnar motor nerve conduction velocity is mildly slow across the elbows without any detectable conduction block. And I can't read this because my stuff's in the way. Let me see
Yeah.
if I can
Yeah.
correct. Nope, I need to cancel that. Um,
No.
Adjacent here, let me turn this down just a hair so I can see
Okay.
it. Still can't see it. There, now I can see it.
Okay.
Sorry, on my screen as a presenter, it has all kinds of options and a big table over on the right hand side of my screen that is in the way.
Gotcha.
So it's covering up my stuff.
Oh
But
yeah.
that's just that's the GoToWebinar. So mildly slow across the elbows without any detectable conduction block or temporal dispersion. Adjacent NCVs, latencies, amplitudes are normal. Bilateral distal ulnar sensory response is normal. Then other stuff that's normal. EMG is normal. So abnormal study, evidence suggests mild ulnar focal neuropathy across the elbows bilaterally. So that's a pretty straightforward ulnar, a suspected ulnar neuropathy at the elbow, and
Okay.
data that you would find in report.
Got it.
Anything you might add to that?
Uh, I don't think so. I mean, I
That's,
think it pretty much is straight and to the point.
yep. Now I
You
think
know, I
that if
think that
that data submitted for your ECS would fly.
right.
Okay.
Okay.
So we will cancel that one and go to case 2. All right. Patient describes intermittent hand paresthesias worse on the right, predominantly at night when sleeping, during the day when he's driving, when he's talking on the phone. Now, what does that sound like?
Hmm. I mean, that
Sleeping,
does sound like more of a median.
yep. Driving, talking on the phone. That's
Yep.
classic
Yep.
carpal tunnel.
Yep.
Symptoms involve the entire hand, 1 through 5, and on the
Mm-hmm.
right hand, predominantly involving digits 4, 5.
Mm-hmm.
Or,
Mm-hmm.
I'm sorry, predominantly 4, 5 on the left.
Yeah.
Uh, Clarifying examination is suspected mild left ulnar neuropathy at the elbow with right carpal tunnel or ulnar neuropathy at the elbow with intermittent
Mm-hmm.
symptoms. He
Yeah.
had really no objective sensory deficit, weakness, or atrophy. So when we go down and we look at his data, let's start with his sensory studies.
Okay. So, yeah, we do have the right median. You know, definitely.
So let's get in the habit of saying it like we're going to write it.
Okay. So the right median sensory nerve uh, does have a latency at the wrist, along with uh, a delayed or a slowed velocity. Um, and so that's basically as far as the sensories go.
So
Um,
let's say that again.
okay,
There is a delayed latency
latency.
from
Okay,
wrist to digit with slowed transcarpal velocity.
okay, okay. I've got to learn how to put all these together.
It's okay.
It's a delayed latency from wrist to digit.
Yep. And slowed transcarpal velocity.
Slowed transcarpal.
So the palm to digit latency is normal.
Yeah, absolutely.
So we don't want to necessarily characterize this problem as just a diffusely slow median nerve. It's not. It's focally slow
Yes,
across the carpal tunnel.
correct.
Okay. So that's how we want to say it if we can.
Okay.
What about other sensory things?
Oh, let's see here. Of course, with our comparison to um, of median to radial, you also see a I haven't really done comparison. Would you say it's just abnormal difference, or would you call
Yeah.
it
Yeah.
okay abnormal difference in latency? Um, and let's see. I'm not sure what is delta p. I'm sorry, I'm not.
Is the difference between the median and the radial.
Okay, that's all it is. Okay.
Yeah. It's a
So,
peak latency. It's delta peak. So it's the
okay.
difference. And if you've not done comparative studies, you need to learn them because you
Yeah.
may see patients that are, when you do the palm to digit and the wrist to digit comparison is a
Hmm.
comparison. You may see a normal latency from wrist to digit, but a slowed transcarpal segment.
Yeah.
When you see that, you should consider doing another comparison like median radial to digit 1 or median ulnar to digit 4 in carpal tunnel.
Okay.
And we'll go over those
Yeah.
as well. In fact, we'll do more of this carpal tunnel stuff next time I do a webinar.
Good.
So what I would say in one sentence here, when I look at this sensory data, is that the right median latencies are delayed to digits 1 and 3 with slowed transcarpal velocities and normal amplitudes.
All right.
And I said what I see in one sentence.
Are slowed from 1 to 3.
Yep, digits 1 and 3 are slowed with slowed transcarpal velocity and normal amplitude. So we've characterized the median sensory responses on the right side. The second sentence I'm going to say is in dealing with the right median motor. There is a mild motor distal latency in the right median motor response with normal amplitude and forearm velocity. And now I'm done with the median nerve.
Okay.
What about the ulnar nerve?
Well, we have normal latencies, but again, if you have to say you have a mildly slowed cross elbow velocity um, of the left ulnar motor segment.
Mm-hmm. My next sentence would say short segment testing confirms that this occurs at or just proximally to the medial epicondyle. And that's what those inching technique is right there.
I've actually done that once with Mahini.
Good.
Yeah. Yeah, I actually had a patient she wanted me to go back and do. So I have done it once. So
Good. Good. And then otherwise, the right ulnar motor to both the ADM, FDI, and short segment testing shows normal nerve conduction findings. Right?
Yeah.
That's okay.
Yeah, I'm just like I said, I'm just trying to take this all in. Like you say, it's so we with the ulnar inching we see it, but when we go back and we're doing so basically we're stimulating because I think I did this with one other that you had, is we're still stimulating the same way um, that we're doing through minimus, the same pathway as we're doing through FDI, correct?
Yes, that is correct.
Okay, so we're doing that, but then across the elbow, we were normal.
On the right side, we were.
Okay, I'm sorry. I got too caught up in that one. Yes, so the left side we were
It was slow on the left, and
slow on
short
the left.
segment tests on the left showed
Okay,
normal or showed slowing at or just proximal to the medial epicondyle.
okay.
But all
So
the right ulnar stuff is normal.
so you didn't do FDI on the left.
No, because I saw it abnormal at the ADM. I didn't feel like I
Okay.
needed to.
Okay. That's what, like I said, I just trying to sink all this into it. So with normal, if I'm wanting to make sure, I'm going to do both
Yep.
to confirm it. And then if I see it on the side with when I'm doing ADM, then I'm not concerned to look at it again.
Not if you confirm that it's slow. That's
Okay.
right. So, and
All
that's
right.
really what the practice parameter tells us. What the practice parameter will say is in suspected cases, and remember that EMG nerve conduction is an extension of our physical examination, right?
Right. Right.
So in all of these cases, their physical examination and their complaints were suspicious for ulnar neuropathy at the elbow. Therefore, I need to do whatever I can to demonstrate that it's there or not.
Hmm.
So once I demonstrate that it's there, there's really not a lot of need to keep hammering that it is in fact there.
Hmm.
You can if you want, but once
Right.
I see that I've got a slow segment around the elbow on the left, I don't really need to confirm it. You can confirm it testing off the FDI, but when I go to the right and I test a traditional study across the elbow on the right that's fairly normal,
Hmm.
but I still suspect that they may have ulnar neuropathy at the elbow, the FDI becomes my fallback.
Okay. I
And if
understand that.
that's normal, I may choose to do short segment testing just to make sure.
Okay. Which is what you did.
Yep.
Okay. All righty. It helps to see it.
EMG again was clean.
Hmm.
Similar selection. Left side, ulnar samples. Right side, I get
Hmm.
my ulnar samples plus median.
Okay. Okay.
Again, waveforms reasonable.
Hmm.
I like to superimpose my inching. And that's two good inching studies side by side,
Hmm.
and you can clearly see where the problem is.
Yeah, you sure can. Yeah, if it stands out.
And so how do I write that? Again,
All right.
I'm gonna slow this, get this so I can see the whole thing.
That's all right. Yeah.
So right median sensory latencies delayed to digits 1 and 3 with slowed transcarpal velocity and comparably low amplitude to the left. Ah, I didn't notice that when we were looking at it. Look at there. 54 versus 27. There's a 50% difference side to side.
Oh yeah. Jeez.
We didn't catch that, did we?
No, no. I.
That's all right. I didn't catch it either as we were going through that, did I?
Hmm.
It's all right. But when I write my report, I want to see it though.
Absolutely.
Mild right median distal motor latency slowing with otherwise normal findings. Left median motor and sensory nerve is normal. The left ulnar motor NCVs mildly slow across the elbow, with short segment testing confirming slowing that occurs at or just proximal to the medial epicondyle. If you want to, you can put in parentheses retroepicondylar groove
Mm.
because that's proximal. When it's distal, it's at the humero-ulnar arcade or HUA.
Oh my.
Or you can just say just distal also.
I
Left
might
ulnar
just say,
sensory NCS is normal.
yeah.
Right ulnar motor and sensory is normal, and superficial radial sensory studies are normal. So it's an abnormal study. There's a mild right median focal neuropathy at the wrist, also a mild left ulnar focal neuropathy at the elbow.
Okay.
Pretty straightforward.
Yeah.
Anything else that we want to add to or take away
I think you found the one thing we missed, or that we didn't see, that's in the report.
with the sensory comparison?
Yep. Yep.
But it's okay. At the end of the day, I would still consider that to be mild, possibly mild to moderate. just given the amplitude. But I tell you what,
Yeah.
if they had only had symptoms on the right, I'd be calling that mild all day.
Mm-hmm.
Had I only done a right nerve study, I wouldn't have called that anything other than mild.
I got you.
Okay,
Yep, I got it.
let's do a couple more.
Sounds good.
Okay, another one. Suspicious mild owneropathy at the elbow, left greater than right. Intermittent, improved with shaking the elbows, with provocation, with Tennell's at the elbow, and as well as an elbow flexion compression test. No atrophy weakness at all. So this looks just like a bilateral cubital tunnel, right?
Yes, absolutely.
Let's look at the data. Anything on our sensory studies?
Well, I don't see anything outstanding. There is a little difference in velocity, transcarpal, but doesn't look like a significant difference between left and right.
Yeah, I wouldn't consider that. I mean, a 3.3 and a 3.4, and then a 1.9 and 1.8.
Yeah, I was just looking at your velocity at 50 and 44, but that was, I'd say, pretty much normal.
They're
Nothing
normal.
else. Yeah.
And so if you had suspected that, what's an alternative that you have? So say you
Well,
thought, hey, that 44, maybe that means something. What else could I do? Just based on our conversation tonight.
um, well, I'm gonna say I'm trying to think. You could,
Here's a hint.
yeah, do the median radial. Yes. Yeah, definitely a big hint.
And interestingly, there looks like there's a comparative difference,
Yeah.
but the latencies are okay.
Mm-hmm. Mm-hmm.
And I don't know that that means anything to me.
Mm-hmm. I got you.
So then I do motor studies.
All right. Well, the wrist, we don't look too bad. Those don't look bad.
So the medians look good.
Yeah.
Traditional ulnar motor studies look good.
Yep. Sure do.
So then because I still suspect, now remember, this is an
Correct.
extension of my physical examination. They've got
Correct.
provocation with Tennell's and with elbow flexion compression. So
Mm-hmm.
when I see these guys are normal,
Mm-hmm.
then alternatively, I'm going to go to the FDI.
Yes.
Well, when I go to the FDI and I do those, is there anything abnormal there?
Mm-hmm. Well, I think your velocities are good. Oh, what about our? Because we're still going on the 3.6, right?
No.
No?
No, you can't. You're talking about for latencies here?
Right.
No, you can't do that.
Okay.
Why can't you? And that's a great question. And
Yeah.
there's a reason why we standardize our tests from ulnar motor to the ADM. And the reason is because it's easy to get a standard 8 centimeter distal motor latency.
Okay.
We don't have a standard ulnar FDI because not everybody's hand's the same size.
True.
You
Let's
know,
say
you take Mohini's hand and your hand,
oh yeah.
and the distance from the wrist to your FDI is much larger than
Yeah.
from Mohini's wrist to her FDI.
Correct.
Yet
Okay.
you could each have a standard 8 centimeter segment distal motor latency to the ADM.
Very true. And you look
That's
at, if you're doing left and right comparison, you're actually seeing similar speed, but it, like I said, I don't know you can really make any inclination based on that or not. I mean, you're looking at your velocities look great.
Yep. Well, they look pretty good. This
Yeah.
this makes me go, hmm.
Does it?
Well,
So,
just makes me go, hmm. So what's the
because,
next step?
uh,
It made me go, hmm. So I did ulnar inching.
over inching, yeah.
And when I inched, what do I see? Point 0.5, point 0.3, point 0.5, point 0.4. No significant linear changes there.
Yeah.
Point 0.4, point 0.5, point 0.5, point 0.4. No significant linear
Mhm.
changes there. When we look at the EMGs normal,
Yeah.
and when I look at those inchings, there's
Yeah.
really not anything that's just jumping out at me that looks abnormal.
No.
So because of that, when I write, I like to say, despite
Mhm.
clinical symptoms of suspicious mild cubital tunnel syndrome, there are no abnormal electrophysiologic findings to confirm any significant ulnar focal neuropathy at either elbow.
Yeah. Yeah. I know you're going to find that from time to time.
Yep, and it's okay.
Yeah.
So at the end of the day, here we have a patient that presents with bilateral cubital tunnel syndrome, and both ulnar motor nerve conductions are normal, recording from both the ADM and FDI, including short segment tests across the elbow.
Mhm.
Ulnar sensory nerves are normal. Median motor studies, sensory, and superficial radial studies are normal. So everything in this case, despite the fact that this patient has clinical cubital tunnel, they don't have detectable focal neuropathy.
Mhm.
And you're going to see that. It's okay. It happens. What's
Yeah.
what's most important is that we've exhausted the tools that we have to see it or not see it.
Okay. Yeah. I understand that.
Okay. Anything else on this study?
No, I think you have covered it all.
You feel good about it? You feel like if this person comes into your clinic, then you can do these things?
Oh, I think I could. Like I said, I've got a little bit more to expand, and probably I would do a little bit more practicing on inching again.
Good.
I've got to do a little work on my radial comparisons since I haven't done that, but that's not a big deal. I just need to do it.
You can also choose to do median and ulnar to D4. That's an easy one to do too.
Okay.
And you can also do a median to lumbrical versus an ulnar to palmar interosseous study.
Oh my.
That's we went over it with Dr. Kimura,
Yeah,
and you'll go over it. Which courses have you been to so far, Roy?
just
Just one
one.
or just
Yep,
one?
just one. Yep, and I will
So,
be back there again in January for the
okay,
residency.
so you'll get all that. You'll get all of those other things in the residency portion then of two.
Okay, and I'll be that one in April.
Okay.
Yeah.
So the last case, left upper extremity paresthesias involving digits 4 and 5. Very well detailed. Intermittent hand paresthesias involving 4 or 5, aggravated with elbow arm. I don't know what else is there. Positioning improved with movement.
Hmm.
Aching in the medial forearm and elbow. Occasional neck pain. She's got provoked symptoms with forced elbow flexion compression. Tunnels at the median nerve at the wrist. Ulnar nerve at the elbow is normal. No motor weakness. MSR is normal. Sperling's negative. Nothing.
Hmm.
Does have thyroid problem, well controlled, non-insulin dependent diabetes. Here we're suspecting left ulnar neuropathy at the elbow more so than lower cervical radiculopathy or lower brachial plexus.
Hmm. Hmm. Okay.
So we go to her study. I threw you a curveball here. Sensory nerves.
Okay.
You've never seen this before,
No.
and it's okay. You can test the ulnar sensory nerve around the elbow.
Okay.
It's doable. You can measure from onset or from peak, and in this scenario, I did both. The
Okay.
normal using a peak latency is greater than 53 meters per second. Normal onset should be greater than 55 around the elbow.
Mm-hmm. Mm-hmm.
You cannot pay attention to these amplitude changes when you lengthen a sensory segment due to a phenomena called phase cancellation.
Okay.
Phase cancellation is the reason that your palm is always going to be larger than your wrist. There's a component of phase cancellation there as well.
Okay.
But once you lengthen that segment longer and longer, like 21 centimeters,
Mm-hmm.
you see 26 turn into 12.
Gotcha.
And that's normal.
Mm-hmm.
And then
Mm-hmm.
as you move proximally, it's even smaller.
Gotcha.
Okay. But in this scenario, we see slowing in the across elbow ulnar sensory study,
Mm-hmm.
measuring from both peak and onset latencies. When we go down to her ulnar motor nerve conduction, what do we see?
Okay. Well, we do have, let's say, fairly normal until you get down to your inching.
Right. Part of the reason why I went back and did the sensory. I was looking for something else to
Yeah.
help me to demonstrate that there was ulnar neuropathy at the elbow. Clinically, she has it,
Yep.
but these studies, pretty
Mm-hmm.
clean.
Mm-hmm.
FDI study, right at the limit of normal. So I'm
Yeah.
going to inch from the FDI, and lo and behold, bam, we see it at the
Mm-hmm.
HUA. Median motor study was normal. Median radial comparison to D1 was normal. No difference.
Mm-hmm. Mm-hmm.
EMG was normal. There's your sensory study. Cross elbow,
Yeah.
below
Yeah.
elbow, across elbow. And boy, plain as day, you can see that
Yep.
inching.
Sure can.
So how severe would I call this? I see it only in a short segment
Um,
and in an alternative study around the elbow. Everything
Gosh,
else was clean.
I don't know. I still think it's pretty just mild.
I'd say very mild.
Yeah. It's like you
So
caught it early.
in the writing, left ulnar sensory is mildly slow across the elbow with otherwise normal findings. Traditional study of the left ulnar motor from the ADM and FDI doesn't show any significant deficit, but short segment testing does confirm mild focal slowing at or just distal to medial epicondyle. Otherwise, everything we tested was normal. So evidence suggests very mild ulnar focal neuropathy at the left elbow, only detected with short segment motor testing and across elbow sensory nerve conduction. No other abnormalities.
Yeah. Yeah, I tell you, our physiatrists around here do not go in that, and neurologists do not go to that trouble working to find.
No, they don't.
Now,
And so some could say that if traditional tests don't demonstrate it,
hmm
then the problem's not there. But we know that the
right,
problem is there because the patient says that they've got the problem,
correct,
and you can provoke it.
absolutely.
Now, is this a patient that you want to hurry off to a surgeon to
No,
decompress?
not at all.
No.
No.
So some might say, well, because you're doing things to try to find the problem, then you increase the risk that the patient should have unnecessary surgery. Well,
Hmm.
I guess that's true if they're seeing a crappy surgeon,
Yeah, I
but
agree.
but a surgeon who sees that the patient's provocative, maybe the patient has an ulnar nerve that subluxes. They have very provocative symptoms and complaints, and they have a normal nerve study. They still may do surgery on them.
Yeah,
But I think it's important to use the tools that we have to confirm or deny the presence of the condition. And what the practice parameters tell us is very specific.
mhm,
Test the long segment. If the long segment's normal, shorten it or do a comparative study. And so the alternatives that we have for the ulnar nerve are, if the standard ADM segment is normal, alternatively test from the FDI and potentially do a short segment inching technique. Whether you choose to do 2 centimeters, 2.5 centimeters, or
mhm,
whatever,
mhm.
go short.
Right, right,
Same things are true for carpal tunnel.
right. Okay, that gives me a lot to think about. I'm seeing mainly in that carpal because I've got some right now I need to get to. We've been so slammed here and so many
Okay.
different directives, but they're all into that same boat. Similar types of issues with carpal and some ulnar.
Okay.
Well, actually, the last one I did. But sometimes it's kind of hard going because, like, the gal I've got right now, we've got multiple neurological issues as far as, I should say, neurological pain issues, neck and back with radicular types of symptoms. And, you're sitting there going, well, she says her whole hand is numb,
Right.
from the standpoint. Um, and we look at, and of course, I don't know. Do you ever find that as you're doing some of the testing that they don't really know how to describe their symptoms and they externalize it to the full extremity? Their awareness is poor.
Yeah.
You
Yeah, that
know.
happens all the time. And part of doing a good physical exam is not necessarily leading the patient. When
Right.
I do an elbow flexion compression test, I push on the ulnar groove, I flex the elbow, and I don't say a word.
Oh yeah.
And if I say, some patients you can say, uh, tell me what you feel, and they'll
Hmm.
say it hurts where you're pushing, and I
Yeah.
say okay, and then I'll hold it and I'll say anything else. It
Hmm.
just hurts where you're pushing. Well, that's a negative test.
Right.
It's
Right.
it's like doing a Spurling's and somebody goes, "Oh, that hurts." Where?
Hmm. Hmm.
If it hurts at the cervicothoracic junction, well, okay,
Yeah.
is that it? Yeah, it hurts right there.
Hmm.
And it's so they've not said, "Hey, that's making my thumb and my ring finger go to sleep," or "That's making
Right.
it hurts all the way down my arm."
Right.
That if you lead them too much, then again, I this is
Yeah.
kind of funny. When I used to do a lot more spine,
Yeah.
and used to do a lot more Waddell's and those types of things and
Mhm.
FCEs and that, I
Yeah.
would do a I would do a classic toe flexion test, and I would say, "Now I'm going to bend your toe down, and you let me know if this bothers anything." And
Yeah.
I would hold their foot and I would flex their toe. And I've had patients like come off the table that they had so much back pain from me flexing their
Hmm.
toe.
Hmm. Oh yeah, I used to do a lot of that too. I did 4.5 years of nothing but workers' comp. So
I had a
I did a
patient
lot
one
of it.
time, this is no lie. I looked at him and I said, "Now, tell me, when I look deep into your eyes, does it make your back hurt?" And I started staring at him and I was kind of looking real hard in his eyes. And he said, "Yeah, that's starting to make my back hurt."
Oh yeah, oh yeah. You
So,
get some doozies.
but having said that, you know, It's not unusual to see a patient with carpal tunnel that says their whole hand hurts.
Oh yeah, and
And
that's the
it's
gal
not
I've got right now. But
yeah,
she has a history that goes along with it too, so you can kind of break down just from her history that there's a good possibility the carpal tunnel is her main issue.
there you go.
Yeah,
And you'll see a patient with ulnar neuropathy and they'll say it's my last three fingers.
yeah.
They'll say my middle finger and my ring finger and pinky bother me.
Mhm. Yeah.
And I used to say, God didn't give us a textbook of correlative anatomy and symptoms with what it is we're supposed to say we feel when we have a certain condition.
Mm-hmm.
It's just like you'll ask a patient, do you have any numbness or tingling? And they'll say no. And then a few minutes later they say, but my hand itches and feels like it's getting stuck with pins.
Mm-hmm.
And I'll say, well, I asked you if you had any numbness or tingling. And they said, I know you asked me that. I don't have any of that. It just itches and feels like pins.
Mm-hmm.
I'm like, well, okay. There.
Oh,
Yep.
okay. So now I'm going to ask you a question too, because I've had some problems with radials, you
Uh-huh.
know, and I've worked in trying to get, but if my only issue is my amplitude is like slightly off of normal, but velocity and latency are fine. And I'm talking, I've done 20, 25 stems and I can't get that amplitude all the way up. I mean, is there,
Now, let me ask you this, because this is a problem that I see.
okay,
I see people are unwilling to fully depolarize a nerve
yeah,
for to minimize motor artifact.
yeah. I'm not trying to minimize. Now,
Okay.
when I talk with Mark, though, he has told me that on his sensories, he doesn't go much over 35.
It depends on how fat the patient is, but
Yeah,
typically that's,
yeah.
that you got to be
Yeah,
willing to
I've
do
had her
all.
up into the, like this one I had here, I had her up in the 40s anyway. I've seen
Okay.
her just, like I said, but I'm hitting it, but like I said, I'm right close, but I'm not there. So,
Where's your recording electrode?
the recording electrode for radial,
Hmm.
yeah, let's say it is at the, um, trying to sit here and think. It is the, um, at the thumb,
Where in the thumb? All
right,
the
right
way.
at the PIP.
Oh, so your recording electrode is at the PIP and your
Yeah.
reference electrode is out on the
I'm
IP.
sorry, and my mistake. I'm at the MP with the recording electrode, and I'm at the PIP as my other. Sorry,
So you're at the MCP.
MCP, yes.
Yeah.
So what am I doing
Yeah.
wrong?
I don't know. You ought to be getting reasonable amplitude. So what are your amplitudes? Like 3, 4, 5 microvolts?
Um, gosh, I wish I had my thing. I could pull it up here.
You ought to be getting about at least a 10 millivolt, a 10 microvolt response there.
Okay, I got to go back and look and see because I don't think I'm getting. I
Now,
can't remember exactly. I'm gonna go back and look at them, and then maybe I'll call you and talk a little bit more.
okay.
We'll try and work it out because I'm really concerned because, like I said, I'm not doing 5. I'm doing 25.
Well, it
Trying to
doesn't
do
matter how
that.
many times you stimulate them. It
I
matters
know.
whether or not you're fully depolarizing the nerve. So
Exactly. Like you
you just
said,
need to be willing to keep turning it up and seeing. Once you keep turning it up and it doesn't keep growing, well, then you've gotten
right.
there.
And that's what I've done.
Okay.
At least I think. I mean, how high is too high?
How
That,
high is too high?
I mean,
Uh,
do I take it all the way as fully? I mean, I'm basically, what I'm trying to do is I watch when it hits and peaks, and that's
and
what
you,
I'm doing. But I'm moving that electrode around, moving, um, the cathode or the anode around at times, just trying to move, trying to see am I just off the nerve?
yeah, that's just practice because I don't do that. So
Yeah,
I
I know.
I
I know.
I,
It's,
I
it's
get
I
on the
know it's
nerve and
a
I
problem.
stim it, and
I
then I
know.
and I stay in one place and I continue to turn up the amplitude until I get a super maximal stimulus, and then I stop.
Okay.
Now, if once I get to that point, if it's not a reasonable amplitude, I'm not going to change my stimulator. I may
Right.
change my recording electrode position to
Okay.
make sure that I'm over the nerve.
Okay. All
Yeah,
right.
that
So
that'll happen, and it's not your stimulator necessarily. If you know you're on the nerve and you're thumping it,
yeah,
and the patient says, "Yeah, I feel that shooting down my thumb and my index finger,"
yeah,
and
yeah.
I know I'm
You got
firing that nerve. Maybe my recording electrode's not where it needs to be.
okay. So I need to adjust that a little bit. Maybe that'll be the difference.
You need to be willing to adjust it. Yes.
Yeah. Okay. Well, that's fine. Like I
So
said,
so
I'm just
maybe
trying to
maybe
get.
you're a little more volar. Maybe it needs to be a little more dorsal.
Okay. Well, that gives me some things to try and troubleshoot what I'm coming up short on. Because, like I
Okay.
said, that's my only frustrating sensory, really.
Yeah, and it shouldn't be. In fact, it is the part of the reason we test radial nerve a lot is because it should be a good normal nerve in a
Yeah.
normal person. And
Yeah.
even in pretty significant polyneuropathies, the superficial radial nerve is like the last one to go.
Okay. All
Now,
right.
you want to be careful and pay attention when you go to test a radial nerve and you don't see it.
Uh-huh.
Start looking for scars because it's also a superficial nerve. And
Okay.
so you may see patients ding it up.
Okay.
That's called Wartenberg syndrome, right?
Yeah. Okay.
A Wartenberg syndrome is a superficial radial neuropathy, and patients will get karate chopped there. They'll get hit there. A
Hmm.
patient will have had somebody try to put an IV there. The patient will say that they had a laceration there, and
Hmm.
and you see a scar there, and you see a low amplitude or a slow response, and it's like, well, okay, I, that's probably due to this trauma here.
Hmm.
Um,
Okay. Well, like I
but
said, that helps.
otherwise, your superficial radial responses should be pretty normal pretty much all the time.
Well, that helps a lot. Like I said, I've got this one gal. I'm gonna have her back. I'm gonna go back and try and retest her, and I'll adjust and see if I can improve on those.
Okay.
Because I mean, that's like I said, I know where I should be from our discussions,
Right.
but yeah, I just have, like I said, and
Yeah, I can
I've
tell
spent a
you,
lot of
I spent a lot of time with another trainee who was was consistently reporting slow, and low amplitude radial sensories,
yeah.
and I was like, no, this is atypical. I mean, I've reviewed more of your work with abnormal radial sensory nerves than I've probably seen in my career of 30,000 of these tests
Yeah.
that weren't radial neuropathies. Now I see it when Saturday night palsies and posterior cord brachial plexopathies, but
Right.
I shouldn't see this in these otherwise normal patients.
Okay.
And as we troubleshot, realized that his electrode placement was what you described.
Yeah.
First, he would put his recording electrode at the IP
Yeah.
and his reference electrode out on the thumb.
Yeah.
Well,
No.
you're talking about a tapered nerve. And
Yeah.
my norm in that position is less than 2.9 milliseconds,
Gotcha.
not 2.5.
Right.
And that's where I test the superficial radial nerve, by the way. When I'm doing
Okay.
median radial digit 1, that
Uh-huh.
that, that electrode's going just distal to the IP.
Okay.
So when you look at my radial sensory responses and you're seeing that they're 2.6, 2.7, 2.8, and only 4 or 5 microvolts, that's normal. But I'm
Okay.
way out on the nerve.
I got you.
I test it different than you've been taught.
Yeah. Oh, okay.
But in the technique that you've been taught
Yeah.
down at the MCP
Yeah.
with a reference electrode at the IP,
Right.
then 2.5 and about 10 microvolts ought to be about what your norm is.
Okay. All right. Well, like I said, I've got her coming back in. Um, she's a little needle.
Needle phobic.
Yeah, needlephobic. She's bilateral and I only got her right side. She said I need to quit. So
Okay.
so I'll come back and I'll redo her radials too when I do that.
Okay. All right. Well,
That
good.
helps a lot, Vic.
Brad, did you ever make it, Brad? No.
Yeah.
Okay. What else you got, Roy?
Uh, I mean, that's it right now. I've got to go through, I've got to write up my studies. Like I said, we just